Welcome to webinar number 233 from the Andean Health Organization, Hipólito Unanue Agreement. It's been already 3.5 years of continuous learning since we started in May 2020. Today, Thursday, July 11, 2024, in the framework of the week of safe and we're going to have the seminar called Racism and Discrimination, a Global Perspective. Racism and discrimination are priority issues as they exist in all modern societies and have a profound impact and serious consequences on the health of disadvantaged individuals and communities. They can also lead to poverty, social exclusion, reduced access to health services, violence, and even death, exacerbating inequalities. It is important to emphasize that for the Andean Health Organization, Hipólito Unanue Agreement, promoting the health and well-being of the nearly 170 million Andean inhabitants is a priority. We work hand in hand with the Ministry of Health so that public policies respect, protect, and promote human rights, being inclusive, equitable, and based on respect for human dignity. To this end, it is essential to strengthen the capacities of intersectoral and transdisciplinary work, as well as strengthening regional integration and international cooperation to help address the challenges facing our countries. In this case, to help address the crisis triggered by racism and discrimination. We firmly believe in the One Health approach that is indispensable to achieve the highest possible level of health in our populations. The development and well-being of our populations depends on what we do now. Reflections on these and other priorities relevant to health and well-being can be found in the Bulletin Noti Salud Andinas, monthly edition, available on the website of the Andean Health Organization and in the Andean Integration Knowledge Showcase. We invite you to read them. Now, we invite you again to leave us your name, organization, and country from which you are joining us through the comment box of the Facebook or YouTube live chat. To access the certificate of attendance to this webinar, as usual, you must fill out a brief survey and leave your data in the fixed link found in these chats. We remind you that you must verify that your email is spelled correctly. That is how we're going to send your certificates. Also, and you can leave your questions in this same space or send them via email to webinarhorasconu@gmail.com. We will begin the webinar with the institutional greeting, followed by the keynote speeches, then to start the dialogue through questions that we will receive from the audience that accompanies us. To begin this important day, I give the floor to Dr. María del Carmen Calle, Executive Secretary of the Horasconu, who will give the welcome and the institutional greeting. Go ahead, Dr. Calle. Thank you, Gloria. Well, we will repeat this, but we would. Racism and discrimination are social problems that affect individuals and communities in various ways. They can lead to poverty, social exclusion, violence, mental health disorders, and even death. They are a threat to public health because they harm the health of disadvantaged individuals and communities. People from minority groups, such as Afro-descendant indigenous, and Latino populations often face barriers to accessing quality health services, usually due to economic, geographic, linguistic, or cultural factors. According to studies, racial and ethnic minority patients may receive different or less effective treatments compared to white patients, even when presenting with the same symptoms and conditions. Black women in the United Kingdom are 4 times more likely to die in childbirth than white women. In the United States, blacks and Hispanics are more likely than whites to be exposed to environmental hazards, especially hazardous waste. In Latin America and the Caribbean, the health problems of indigenous, Afro-Latino, and Afro-Caribbean populations are often related to lack of access to health services, whether due to geographical dispersion, cultural aspects, or lack of adequate information. It is therefore necessary to adopt special measures to make health and other social services more accessible to these populations and more responsive to their needs. In addition, the reason why minorities are at a higher risk of disease is because in some instances they have not been adequately screened by health professionals. Systems that reproduce racism and xenophobia need to be transformed through anti-racist public health interventions, such as education programs that reduce prejudice towards discriminated groups and improve the cultural sensitivity of healthcare providers. Healthcare professionals may have unconscious biases that can lead to misdiagnosis or underestimation of the disease. Another important aspect to consider is the development and implementation of health policies that recognize and address the special needs of minority communities and promote research that analyzes racial and ethnic health disparities. Collect disaggregated data to better understand and make responsive decisions. This becomes indispensable. The Andean Health Organization Hipólito Unanue Agreement recognizes that the eradication of racism and discrimination is fundamental to achieving a more just and equitable healthcare system and reaffirms its commitment to continue working towards this goal. This webinar seeks to add the efforts being made for the full exercise of this right, with two excellent speakers who will share their experiences in this important issue. Dr. Baltica Cabieses, Professor of Social Epidemiology at the University of Chile, and Dr. Dylan De Vacumar, Professor of Global Child Health at the University College London. Welcome both. Welcome all. Thank you, Dr. Calle, for your words. After the greeting of our secretary, I will introduce myself. I am Gloria Lagos, Manager of International Cooperation and Coordinator of the Health Committees of Migrants and Mental Health in our institution. And I am pleased to be in charge of moderating this webinar. We will begin the lectures by extending a warm welcome to Dr. Dylan Devakumar, Professor of Global Child Health at University College London and honorary consultant in public health. He is a public health specialist with clinical experience in pediatrics and humanitarian settings. He is co-chair of the UCL Center for Women's, Children, and Adolescent Health. He directed the Lancet series on racism, xenophobia, discrimination, and health, and is director and founder of the Global Health Group, Racism and Health. He was a commissioner and steering group member of the UCL Lancet Migration Commission. He is chair of the new Lancet Commission on Racism and Child and Adolescent Health. Welcome, Dylan. Go ahead, you have the floor.
Thank you very much. Thank you for inviting me to speak today. It's a great privilege to speak to you. I hope you can see my slides, and is that all okay? If I'm speaking too quickly, tell me and I will slow down and change. So again, thank you for inviting me to speak. I'm going to talk about racism and discrimination in a global setting. So my three broad key messages that we started the work with was around a wider recognition of racism, xenophobia, similar forms of discrimination as determinants of health, and that this is a global health issue. This happens in every society around the world. And there are similar drivers and consequences based on someone's caste, ethnicity, indigenous status, migration, race, religion, skin color. All of these factors have similar health outcomes. And that we should focus on structural issues. People tend to think about racism at an interpersonal level, where one person experiences violence or abuse, but really it is the structural causes that lead to those health consequences. Broadly, I will be drawing on these three pieces of work: the Lancet Commission on Migration and Health, and then series on racism, xenophobia, discrimination, and health, and our new work coming up on racism and child health that we're currently working on, that Professor Baltica is part of as well. So my work began in 2019 on racism, and 2019 was a time when nobody talked about this issue. But then in 2020, things changed. So the COVID-19 pandemic saw racism come to the fore. We saw East Asian people in particular face violence and abuse. We saw the exclusion of migrants at borders. And then the murder of George Floyd in the USA saw a number of protests around the world, Black Lives Matter protests, asking for racial justice in the US, but in many countries around the world. But it's important to say this is not about one bad person committing a racist act. This is about the fundamental and deeply rooted systems of oppression that result in the deaths of innocent people. If we look at COVID-19 in the United Kingdom, this is a graph from our Office for National Statistics, and it shows that Bangladeshi women had a 4 times increased mortality from COVID-19 than white women. Bangladeshi men had a 5 times increased mortality than white men. And why is this? There shouldn't be any differences in mortality in these groups, both in the same country. But Bangladeshi people are more likely to work in industries that bring them into contact with other people. So work in service industries, for example, and Black people more likely to work in healthcare, for example. They're more likely to live in overcrowded households and pass the infection from person to person. They're more likely to have barriers to access the health service. So migrants, for example, in the United Kingdom, face a charge for accessing health services, even though in this example, COVID-19 should have been free, but people still don't understand those barriers. And they're more likely to have underlying diseases, non-communicable diseases, that will put them at higher risk of mortality. So what is racism? We defined racism as an organized system that affords power and privilege according to an established hierarchy that's based on racial categories. It protects the rights, power, livelihoods of those at the top of that hierarchy. Xenophobia being a similar concept, but about discrimination, hatred of those who are considered foreigners. And then discrimination, unfavorable treatment, differential treatment to those from those groups based on their identity. So for racism to exist, it needs racial categorizations. And it's important to say these are social categories. These are not biological categories. These were based on Europeans from the 1700s, Johann Friedrich Blumenbach, Carl Linnaeus, who came up with these categories of white and black, for example, the colors that we see. But Linnaeus went a step further when talking about the different categories and described characteristics that are associated with them. Americanus being obstinate or merry, Asiaticus, melancholy, haughty, Africanus, indolent, negligent, and Europeanus being muscular, inventive, governed by laws. They assigned these categories, but essentially placed them in a hierarchy of which ones were better or worse. And within science, these ideas have run throughout history. An example is eugenics. So I say this as professor of child health based in University College London, and this was the home of the eugenics movement. So according to Francis Galton, the famous statistician, eugenics deals with what is more valuable than money or lands, namely the heritage of high character, capable brains, fine physique, and vigor. It aims at the evolution and preservation of higher races of men. These are men that are like Francis Galton. So essentially, the eugenics movement divided the world into two groups, those who are worthy to give life and those who are not. The UCL inquiry into the history of eugenics described how eugenics is still present in today's science and culture. Around the world, eugenics of one form or another is implicated in compulsory sterilization, legislation on mental deficiency, immigration law, racist policies, the notion of natural intelligence, normalization of segregation by race, ability, and class. These factors live on within science and within medicine and healthcare. So within our work, we looked at racism and the health effects on people. We started with the individual person, and we looked at the consequences of racism for those people. We organized it by life stage, so birth, childhood, adult, older life, and looked at behavioral, psychological, physiological causes. And we see a huge number of health consequences of racism. We see them right from the start of life, from being born, low birth weight, having a higher mortality rate. As was mentioned previously, the higher risk of maternal mortality in the United Kingdom, for example. We see mental health issues, nutrition issues, malnutrition within childhood. We see higher rates of diabetes, obesity, cancer risk in adults. All of these things, including into older age and dementia and lower life expectancy. We see huge numbers of health consequences throughout life. And how does this happen? This is an example from my colleague Ian Paradis, who worked on the review. So he describes these three pathways. The direct pathway along the bottom, assault, and these are maybe the obvious. Someone gets attacked on a racial attack. We see denial of services and goods. We see people who don't get access to the health service, for example. But there's also this middle pathway of psychological stress And this has been described in many ways, famously by Arlene Geronimus as weathering. So repeated chronic stress over above what the system can maintain or respond to results in these psychological, physiological consequences, resulting in non-communicable disease risk, mental health risk as well. So then what we did was we put the person in the communities that they live in. And those communities can be physical communities where people live, or increasingly electronic digital communities across the world. And these communities can be protective of people, but can also lead to racism within the community as well. We then situated those people within the locations that they live in, the global contexts. We see differences in where people can live, these structural forms of racism, where certain people live in places that increase their risk of poor health outcomes. For example, in London, where I am, air pollution is a risk factor that affects certain populations, Black, Bangladeshi populations, more than white populations. We did a global review of this led by my PhD student, Abhi Devanagam, we looked at the effects of climate and racial justice around the world. And we see that these racially minoritized groups, migrants, indigenous people, are more vulnerable to climate-related impacts and disproportionate burden of morbidity, mortality around the world. But we also see an unfairness here, that the people who contributed to climate change are not the ones who are facing the health consequences. If we look at cumulative emissions of carbon dioxide, 92% of those who are responsible for from global north countries, the high income countries, are responsible for 92% of historical carbon dioxide emissions. But if we look at these maps, we see these dark colors across sub-Saharan Africa, South Asia. The consequences of climate change are happening in those locations.
Could you slow down, please, Dylan?
Yes.
Thank you.
Sorry. If you're interested in this work, there's a link at the end to our Envisioning Environmental Equity project, where you can explore this and see more about this. So we then thought about the structural causes, and we looked at the two issues of separation and hierarchy. So we described these processes of structural discrimination and the idea of separation, where people divide themselves into groups. One group is different from another group. But then importantly, those groups are put into a hierarchy where certain people are given privilege, capabilities, resources, whereas other people are not and are kept below. And these structural forms of discrimination really are the ones that lead to the consequences that we see. So if we think about migration, we think about health restrictions at entry, and these are not permissible on health rights, on human rights grounds. We reviewed the literature and found that people who are detained, for example, face higher health risks. And the solution to this is really to integrate migrants. And Professor Bhattacharya will talk more about this, I'm sure, in the next talk. And ultimately, these are political decisions. Some of the leaders of the biggest countries from around the world have espoused political agendas that exclude certain people, that demonize certain people, that scapegoat certain people. And the consequences that we see, that health professionals see, are resulting from these structural forms, these political reasons. And then finally, we looked at the health systems and institutions that go from the structural causes to the individuals. We mapped out the many ways in which racism can exist within a health system. It can be overt acts of racism. But a lot of this is not about that. This is about the ways that the system may be inaccessible for certain groups, may exclude certain groups for other grounds, may be about understanding, interpretation, language issues within the health system. And one example here is the treatment of undocumented migrant children within the United Kingdom, where I live. So undocumented migrants lack the documentation to show that they are within a country. They lack the regular migration status. There are 120,000 children who are undocumented in the United Kingdom, around half of whom were born in the United Kingdom. And these children face charges up front when attending the health system, so secondary care charges that can be higher than the normal charge for a resident, up to 150% of the normal tariff. And also, if these parents go into debt, they could be referred to the Home Office, our version of border control in the United Kingdom. So what does this mean? Children are not taken to the health facility. They're not treated as they should do. Parents, if they take them, they may take them late, and they may present with a more unwell state. Newborns are affected because pregnancy is charged, and then safeguarding issues around treatment of abuse, for example. And then we put this together and we added a circle round to indicate the life course consequences. Racism affects people in different ways at different ages. And then this arrow of intersectionality that I'll come to. So thinking about the life course, my former PhD student, Susanna Corona Maioli, led a review looking at unaccompanied minors, so people who don't have the adult or parent to look after them. And she mapped this around the world, looking at the many causes of ill health amongst these groups. Her work was particularly in Mexico, looking at Central American migrants who were moving through Mexico to the United States. She found huge numbers of health consequences, physical health, mental health, injury, violence that these young people are exposed to, but also potentially protective ways in which they may show resilience and may be protected. And then one of our papers looked at intersectionalities. So we mapped situations around the world. We had case studies from different countries around the world, and we looked at the different kinds of racism, discrimination in different places. And then we looked at the commonalities, the common themes between them, this idea of separation of hierarchy, the idea of violence that is perpetrated on migrants or minoritized people, the historical roots, the colonial roots around the world that results in the consequences that we see. And then we looked at what should be done. And there's a lot on this slide, and I won't go into detail, but we tried to map interventions at every level, from the individual to the structural, and looked at what has worked or what hasn't. Largely, the interventions tend to be individual level interventions, but really the most important interventions are the ones that are structural in nature, that can change a system. But what I tend to say is that we have to act at every level, from that individual through communities, systems, and structural, if we're going to have an effect. And then we came up with these 6 key principles that relate back to what was said before as well, that these ideas of decolonization, understanding intersectionality, increasing diversity and meaningful inclusion, reparative justice, a justice framework, active anti-racism approaches, and a human rights-based approach. And I want to end this with one quote. So this is a short article written by my colleague Amy Stevens and myself, and this was looking at a recent move within the United Kingdom towards migrants coming over from Europe, illegal migration bill. And I'll read out this quote, if I may, because this goes to what we as health professionals, I think, are obliged to do. As health professionals, we have a duty of care for all children. We cannot be silent bystanders to overtly health-harming policies. With threats of deportation and detention looming, we've never experienced a time more critical to deliver compassionate, trauma-informed care to children seeking asylum. But it is not enough to simply treat the child's medical conditions. As trusted health professionals, we can articulate the devastating circumstances these children have come from and make a case for their ongoing needs. We must challenge policies with evidence, engage decision makers in discussions around social justice, and participate in advocacy actions. Our patients trust us with their stories, and our response to such a privilege cannot be passive listening. We must both hear and act. So finally, in just a minute or two, if I have time, I will play a short animation, because racism is a very personal thing. And I think I can talk about conceptual frameworks and the evidence, but this goes to some of what racism means to people. And this includes Professor Baltaker speaking as well.
El racismo para mí significa definir a otro como distinto y diferente a mí, de una manera tal que valen menos como persona. Por ejemplo, en Chile, donde yo vivo, crecí en una familia donde el tener color de piel blanco, ojos claros o color de cabello claro tenía mayor valía, y yo, siendo morena, sentí desde muy pequeña que yo entonces era menos bonita, o lo que decía o pensaba importaba menos. En el espacio profesional también he sentido experiencias de ser definida como menor valía por ser latina en Europa, lo que hace que uno viva la vida desde un lugar de más miedo, de mayor inseguridad sobre lo que piensa, hace o dice.
Racism to me is the beauty standard that we have in Samoa. If you look more indigenous or local, people will treat you in a way that is less than they would treat a foreigner.
My first awareness of racism was as a young brown child visiting the UK. It was to feel judged or watched every time I went into a shop or boarded a bus. It was to know implicitly that I was considered to be a different category of person than the members of a more powerful majority. It was to feel that I had to be an exemplary representative of my minority group who was deserving of acceptance, and to know that I always had to be alert to my precarious position. When I returned to live in Sri Lanka, my situation was completely reversed. I was privileged to be a member of the majority, and it was my neighbors, friends, and colleagues from minority groups who lived with the very real possibility of violence that could threaten their homes and lives.
I recognize racism in our school systems, but in the form of colonialism. As a Ghanaian citizen, we were colonized by the British, which means that we had to adopt the British education system. However, years after we have gotten our independence, we are still, to a larger extent, being taught with the same education structure, which to me feels just not right. To a larger extent, the education that most Africans are getting is still colonized, so it makes it very unrelatable to young people.
Racismo é que é errado a gente falar mal da pessoa só pelo jeito que ela é. É muito errado. Então eu ia falar para a professora quem tá fazendo racismo, para ela conversar. E é isso.
So thank you very much to the people who were included, and in particular Mita Hawk, who created this animation. And I will finish there and just leave you with a few links so you can see our work with the different commissions and series. Thank you very much.
Muchísimas gracias,
Thank you
Dylan,
so
por su
much, Dylan,
participación, por
for your
su
presentation,
interesante
for your
ponencia. Sin lugar a
interesting
duda, la
presentation.
discriminación afecta
Undoubtedly,
mucho
discrimination
salud,
affects health in many ways,
que a menudo
which
son muy difíciles de medir
have
porque
been often difficult to
los
measure
efectos pueden
because
aparecer
if
más a
effects
largo
can appear
plazo, ¿no? No
over the long
inmediatamente.
term.
Sin embargo, como bien han
However,
compartido
as you
ustedes,
have shared with
este es
us,
un problema
this
estructural. La
evidence
evidencia
suggests
plantea
it's
que
a
sus
structural
impactos
problem, and
biológicos,
the evidence suggests that its
psicológicos
direct and
son un
indirect
factor
biological
importante
impacts
de
are an important
desigualdades
factor
raciales
for
en la
racial
salud.
inequalities in
La
health.
discriminación genera traumas
Discrimination
colectivos en la
generates
salud
collective
mental,
trauma
por
and
lo
should
que debe de
in mental
reconocerse
health,
como
and
factor
should therefore be recognized
importantes en la
as a
salud.
determinant in
Además,
health.
hay que destacar la
In addition,
importancia de
this
generar intervenciones en salud
importance
pública
generating
tempranas,
anti-racist
¿no?
public
Como
health
programas de
interventions,
educación
such as early education
que
programs
reduzcan los prejuicios
that reduce
hacia
prejudice
grupos
towards
marginalizados,
discriminated groups and
no un poco, que
improve
mejoren, que fortalezcan,
the
¿no? El trabajo y la sensibilización cultural de
cultural
los proveedores
sensitivity of
que
healthcare
ayudan a la
providers,
salud, tal como lo ha
as
señalado.
noted,
Le
should be
agradecemos
emphasized.
nuevamente,
We thank
doctor Devacumar,
Dr.
por esa
Devakumar for your
importante
interesting and
presentación. Le
important
invitamos
presentation,
a
and we
permanecer en la
invite
sala.
you to
Más
remain
tarde
in the room.
terminaremos
At
con
the
el
end, we
diálogo
will
después
have
de las
the
preguntas
Q&A.
que nos están dejando, que ya están llegando. A continuación, le vamos a dar la
Now,
más cordial bienvenida a
we
la doctora
welcome Dr.
Baltica Cabieses,
Baltica Cabieses,
ella PhD, enfermera
PhD,
partera,
nurse,
maestría en
midwife,
epidemiología
master's
de
in
la Administración de
epidemiology,
la Salud
PhD in
de la
health
Universidad de
sciences,
York,
New York, in York
profesora de
University,
epidemiología
professor of social
social en la
epidemiology
Universidad de Chile.
in the University
Profesora
of
senior
Chile.
invitada
She is
en
a
el capítulo
visiting senior
migratorio,
lecturer at the
miembro del
University of York,
directorio de Lance
member of the
Migración
board of Lancet Migration Latin America,
investigadora de la
and
Red
founder of
Nacional de
the Chilean
Investigación
Network
sobre
of
Salud
Research
y
on Health
Rechisam,
and Migration, RECHISAM,
consultor internacional sobre
international
equidad de
consultant
salud
on health
de los
equity,
migrantes e implementación
migrant
de
health, and
investigación
implementation of
científica
scientific
en
research action in
comunidades social y
socially and
culturalmente
culturally
diversas.
diverse
Es
communities.
directora del Centro
Director of
Colaborador
the
de la
WHO
OMS
P-
sobre
CAJO,
fortalecimiento de la
collaborating
equidad
center on capacity
para la
building
salud de
for
migrantes y
migrant and
refugiados en Chile.
refugees in
Bienvenida, doctora
Chile.
Cabieses, a la
Welcome,
sala.
Dr. Cabieses. Go ahead with your presentation.
Muchísimas gracias por esta
Thank you
presentación
very
tan
much for
completa.
this
Gracias
complete
por
introduction.
considerarme en
Thank you for
este tan
considering
importante
me
evento.
for this important
Especial
event.
agradecimiento a quienes
Special
organizan
thanks
este
to the
seminario
organizers
y
of
a
this
Dylan,
webinar
quien
and to
gentilmente
Dylan,
propuso mi nombre
who
para
kindly offered,
acompañarnos en
proposed
esta
my
sesión.
name to
El
participate
día
in
de
this
hoy, en
session.
los minutos
Today,
que se me
in the
entregan,
minutes
quiero
that have been
hablar
allocated,
sobre
I will talk
discriminación racial
about
en las
discrimination and
personas
racism
migrantes y
toward migrants
refugiadas
and
en
refugees
Latinoamérica y el
in Latin
Caribe.
America and the
Para eso
Caribbean.
voy a
For
comenzar
that,
haciendo
I
una
will start
introducción sobre
by
el
an
flujo migratorio en
introduction
nuestra
on
región,
the
luego sobre conceptos
migrating flow and a
esenciales en
concept,
torno a
then
discriminación y
essential concepts
racismo
in terms of
que el profesor
discrimination and
Dylan ya ha
racism
presentado,
that
y
Professor
luego voy a
Dylan has
contar
already
sobre algunos
presented,
estudios que
and
hemos
then I will
desarrollado en
talk about
Latinoamérica
some
y en
stories
Chile y la
in
región.
Chile and the
Les hablo
region.
desde el Centro de
I'm
Salud
speaking from
Global
the
de
Center of
Chile, que también
Intercultural
es
Global
Centro
Health,
Colaborador de
which
Universidad
is a
de Salud en
collaborative center of
Latinoamérica, y que
WHO
busca
and PAHO
contribuir con generación de
to
conocimiento
contributing the
interdisciplinario de
generation of
excelencia,
interdisciplinary knowledge of
situándonos desde el
excellence
sur global
located in
para
the
la
global
comprensión
south
de la creciente
for the
complejidad de la
understanding of the
salud
growing
a escala
complexity
global,
of health on a
generando
global scale,
soluciones
generating
participativas e
participatory
innovadoras
and
que
innovative
ayuden a
solutions
enfrentar los
to
principales
address the
desafíos en
main
Chile y
challenges
en
in
América
Chile
Latina,
and
en
Latin
diálogo con la
America in
práctica
dialogue
y
with
la
the
teoría
praxis and
desarrollados en
theoretical
todo el
debates
mundo.
developed internationally.
La definición de migrante
Our
internacional,
definition of international
conforme a
migrant,
otras categorías de
according to
movilidad
other
en alrededor del
categories
mundo,
of human
se
mobility throughout the
caracteriza
world,
por dos
is
elementos
characterized
generales.
by two
El primero
focal elements.
es que
The
se
first
atraviesa una
is that
frontera política de
crossing
un país
borders
a
from
otro
one
o se
country to
cruza una
another,
frontera y que se tiene
and that
intención de
that's
asentar,
the intending to
sea
settle,
temporal o
either
permanente.
temporarily or permanent.
En este mapa del mundo
In
podemos ver
this
cómo
world
la
map, we
migración
can see how
representada por
migration
personas que viven
represented
o
by
residen
people
en un país
who
distinto del de
live in
origen,
a country
con
different to
estos globos
their
de
origin,
colores, con estos
with these
círculos,
color glows or
con dos
circles,
características. La
with two
primera,
characteristics. The
que es
first
un fenómeno, no un
is a
problema, un
phenomenon
fenómeno
and not a
que
problem, not an issue
caracteriza a todo el
that
planeta.
characterizes the
Y el
entire
mundo
planet.
moderno, con sus
And
fronteras
the modern
políticas
world
actuales,
with
no
current
logra
political
detener
barriers
ni la
cannot
necesidad de
stop nor
desplazamiento
the need
ni
or
la
displacement
intención de
or the
recibimiento
intention of living in a country different to that of the origin. And the other one is that we can see that the circles are larger in the northern hemisphere than in the south, realizing that international migration is usually characterized globally from south to north, and also because there's a higher concentration of international migrants in the northern hemisphere than in the southern hemisphere. I'm going to stop in our wonderful Latin American Caribbean, made up by 20 countries and 7 territories, a continent or a region of which I am deeply in love, and I recognize its high biodiversity, geographically, climatic, and plant and animal, but also in an exceptional preservation of its social and cultural diversity, including multiple languages and cosmovisions. At the same time, our region faces important inequalities and inequities in terms of economic development, human development, rurality, respect and recovery of indigenous people, political social structures, difference in health systems, and also demographic and epidemiological profiles. At the same time, in our region, we have countries that are living with 2 centuries of delay in terms of technology and health response, and countries that are in the cutting edge of technology. In terms of migration flow, we look at Central America. It's characterized because Central America in general wants to be displaced towards the northern hemisphere, the US and Canada, going through Mexico and rebounding in the north border with the US. Many of them stay in Mexico. And then this northern triangle, which is not Guatemala, Honduras, and El Salvador, whose GDPs as country up in 1/3 are made up by the money sent. In the southern hemisphere, we have flow migrating characteristics south, where neighboring countries in South America are being displaced and generating factors of exit, push and pull. Chile in recent years has become a country of attraction, of pulling of people from different countries from South America. I also want to highlight the growing massive exit, the largest known so far in modern history in our planet, of people from Venezuela, more than 7 million, that have displaced to Colombia, then to Ecuador, then Peru and Chile, and to Brazil, Paraguay, Uruguay, and Argentina. It's a massive movement that has transformed the migration pattern and demographic and economical pattern of our sub-region. For Chile, the most important country of origin is Venezuela. It was Peru, our neighbor country, for more than a century. In the last 8 years, Venezuela has displaced Peru and become the first country with foreign population in Chile. Colombia, Peru, Bolivia, Haiti, and Argentina follow. Now I'm going to talk about some essential concepts in terms of, first let's talk about stereotype. Refers to a set of beliefs, usually erroneous, generated by a social construct over time towards a social group, where the characteristics, ways of acting, dressing, among others, of such group are conditioned. The images that you see in this presentation are from studies that we have developed throughout the national territory of Chile and in the region. Prejudice is an emotional predisposition based on a preconceived idea, usually in a negative way, to individual or group members who match certain stereotypes, negative stereotypes. It refers not only to an opinion or belief, but also to an attitude, emotion, which include contempt, disgust, among others. Stigma is a condition, attribute, trait, or behavior that causes the carrier person to be included in a social category towards whose members a negative response is generated and they are seen as unacceptable or inferior. Here we see what Dylan mentioned of hierarchical power relationships between ones and others. The central characteristics from these disciplines is that those groups and those members of those groups are considered inferior or even unacceptable, or that they deserve to be eradicated. The Holocaust that we saw as humankind a century ago tells us about the severity and scandal to which a human being can reach. The stigma from the literature can be conceived as intrapersonal, interpersonal, or structural. In terms of structural, also Dylan mentioned during his presentation. A recent study in Chile of public opinion in general indicated that 77% of people who respond to this survey consider that the arrival of migrants or foreigners to Chile is bad for the country, 21 points higher than in October of 2021 and the highest level since 2016 for our country. The stigma and discrimination and the perception of the migrant population as of less category, inferior, or despicable is increasing throughout the world, in our region, and in Chile. Therefore, the importance of the concept of discrimination that corresponds to placing members of a group at a disadvantage or treating them unfairly on the basis of the real or perceived status or attribute. Discrimination is constituted once a relationship established between individuals and not in the abstract. It is generally visible through a behavior. Its main characteristic is to evaluate and establish an unequal power relationship between the person who discriminates in the discriminated based on domination of the one who is perceived as inferior. Nancy Krieger, a fantastic social epidemiologist that has published a lot on this topic, indicates that discrimination harms people's health and the health of populations. Here, I'm going to give you some quotes of children and adolescents in Chile who are migrants or first-generation foreigners in educational spaces that indicate how they've lived the discrimination in the school and public spaces. A migrant child told us, "It makes me angry, because I'm not as black as the children say. And then there are other Chileans who are blacker than me, and they think that they are so white. And when I tell my mother what happens to me, she gets angry because I cry." A girl told, "They discriminated against me and my friend. We were standing in a store. 'Give us a drink,' we said. And the lady replied, 'Peruvians, we don't give them.'" There are different types of discriminations or categories or dimensions where discrimination can be described and analyzed. According to group, this has to do with the intersectionality that Thailand spoke, and there's growing literature throughout the world, according to the way of discrimination, the degree of accumulation, and Dylan mentioned very beautifully about the intergenerational relationship according to the place where it happens, according to the expression, and according to the perpetrating agent, consider the intrapersonal and interpersonal and structural. Nancy Krieger, in her book, in a chapter for discrimination, talks about three mechanisms. One is indirect interpersonal discrimination through factors that are not easily visible but can establish status or class among people, being ill, particular socioeconomic, educational level, skin color, among others, that give the basis of establishing discrimination. We also have direct interpersonal mechanisms that are visible, being ill or having some health characteristics. What she studied in her chapter with differentiated treatment of certain people by the health team directly compared to others, and the indirect and direct institutional discrimination that's so difficult to measure, but it's acknowledged. And I will tell a very personal case. When I finished my PhD, I had a position in the UK, and when I applied, they said I could stay in a payment category that indicated that I didn't have any previous academic experience, which I already had for more than 10 years because I had never worked in the UK, and they didn't recognize my experience in another continent. So the payment bracket was very well below the what I aspired because of my professional background, but the one I needed because I was living with my husband and my small daughter that will turn 18 years this year. That was several decades ago. And what I would like to comment about the structure, there's no one to finger point, something that you see in the politics, how they find things in social values, but it's not someone indirectly can pinpoint, it's in the air. And there are other authors that I like very much in terms of mechanism. I'm going to mention two. One is about the concept of intergroup anxiety of Stefan and Stephens, that tell us that intergroup anxiety suggests that an adverse emotional reaction occurs when a person becomes aware of the difference between groups and enters in contact with them. This is defined as a natural human reaction, quote unquote, not always conscious, and to the importance of speaking about discrimination, stigmas, stereotypes, and racism, because from there we can become aware in each personal experience. And under certain scenarios, the more intergroup encounters with very good care, we can generate less intergroup anxiety and less discrimination and racism as a real mechanism. The other of symbolic and realistic threat perception of Flockhart that talks about a symbolic threat at the appearance of negative emotions arising from the perception or belief that certain groups, such as migrants, will transform local culture or change national identity, affecting lifestyles and ways of being. And the realistic threat with negative emotions arising from the belief or perception that some group, for example, migrants, will, or indigenous or other groups with certain skin characteristics or educational level, etc., will compete with members of the local society or understood as local for scarce resources and occupy use the public resources or impacting on unemployment, crime. So the other age is always frequent in the symbolic and realistic threat. Gonzalez, a researcher from social psychology in Chile, analyzed in different contexts the ethnic identity, national identity, gender, and social class in Chile, and observed that it is crucial to promote opportunities to promote encounters that are positive, deliberate, in which groups can learn to live in a multicultural fashion with respect, free of discrimination, in democracy and in peace. A couple of final mentions about the concept of racial discrimination or racism, that it exacerbates the racial significance of an ethnic group, emphasizing rejection, and Dylan already mentioned that, but the concept of xenophobia that is related to racism as a reject to persons from other countries. Here I would like to mention some key concepts which are very important to understand. First, racism is intersectional. It's intersectional. It's structural. Thirdly, historically and persistent. Fourth, is colonial and post-colonial. And here I quote Partha Chatterjee in studies of colonization in Europe, in our region of Latin America. She talked about that colonized by the virtue of their biology were considered as incorrigibly inferior in the book in 1993. And is systemic and global and intergenerational, with ancestral traumas, exposure to toxic substances, for example. and those affect the experience of racism of their descendants and their communities. At the same time, it's part of racism and discrimination of structural elements that can be understood as structural social determinants, political, global, economic, commercial, and climate, all intersectional to racism and discrimination. A couple of years ago, WHO launched the first report of health of refugee and migrants and talk about discrimination, racism, and xenophobia. You can read it in this free download in the official webpage. Together with the Pan American Health Organization, a couple of years ago, we did a interactive platform of all the Americas from Alaska to Patagonia about health and migration. And there is a chapter specifically to discrimination where you can find literature and reference associated for the Americas. In the 2 minutes I have left, I'm going to mention 2 studies without some outcomes. The first is this regional study to different countries from our region. And here I'm going to talk about the north border, Peru, Bolivia, and Chile, that in terms of pandemic was closed and militarized and generated hundreds of thousands of people that passed that were irregular, and they are in this an irregular situation in our country with no opportunity to access to many public policies, including education, migratory regularization, among others. The study recognized the vulneration to human rights in the borders, particularly in Chile, Bolivia, and Peru, but also in others in our region during the pandemic, risks to health and risk to life, and sanitary response that were always insufficient, and with the lack support of international organizations and civil society that always arrive first, and with a large response of human capacity of human response. We have some papers published that you can find, and you can download them free. The second study about the experience of migrant women crossing to Chile through unauthorized borders during the COVID-19 pandemic. And here we find as the most important outcomes an institutional reproduction of violence to these women, especially women with children in their arms, walking months from Venezuela and Colombia. Exacerbation of maternal roles in the trajectory in host countries, survival and care, and others versus self-care, and the specific needs for sexual and reproductive health. We have this book with free access that has these illustrations, and you can download completely in that book. And finally, a study from my dear colleague Carreño, a study of childhood and border children who enter Chile with unauthorized borders during the pandemic. Here I'm going to tell you that we found the difficulties in the care of children and adolescents in terms of migration context, hunger, cold, respiratory issues, and infectious parasitic infections, among others. Real experience of racism and discrimination. This Venezuelan woman, a Venezuelan woman, 50-year-old lawyer, that when she went to Chile, in the north border Bolivia, she told us we were stopped by military and they mimicked that they want to kill us. And they counted until 3. I closed my eyes thinking that we were going to die. And then they start laughing. The children still, until today, have nightmares and they wake up thinking that they're going to be shot. There's also institutional bias and reproduction of guilt in mothers and caregivers in Chile due to the experience for the integration and incorporation of discrimination in identity perception, especially in boys, girls, and adolescents. Several articles published that you can also download freely. In closing, retaking the idea of racism and migration discrimination, I would like to indicate that relevant layers, dimensions, and complexity in definitions, theoretical, methodological, and research approaches to these topics throughout the world and in our region, in Chile. The importance of the influence of different types of determinants in the relationship between discrimination and racism and structural dimensions that require thought and serious re-education, especially in terms of health. And a significant regional evidence and from the global south, valuable for decision-making process different levels, with information coming especially from some countries with more research trajectory in this topic. However, there's always the opportunity to continue and expanding. I leave you this Red Chisholm webpage that you can see in the slide, Lancet Migration for Latin America and the Caribbean. And certainly we invite you to follow Dylan with his podcast and all his extraordinary work in racism and health. With this, I conclude. Thank you so much. Thank you, dear Baltica. In Latin America and the Caribbean, the experience of discrimination are intertwined with other forms of rejection and social exclusion. So it is urgent to raise awareness among the population and respect cultural diversity and receive early education to avoid this discriminatory practice, especially in healthcare and the daily, everyday places where you go to buy, where you go to for leisure, to address discrimination in all forms, in personal and social, to achieve a decrease in that and also achieve an impact in the care and health, without forgetting and always considering our boys, girls, and adolescents. We thank Dr. Cabieses for her important presentation. We invite you to stay in the room and we will have a Q&A from the questions that we have arrived. I'm going to stop because we would like to greet all those who join us, especially the officials of the Ministry of Health, the universities, social organizations, and public and private institutions of Argentina, Bolivia, Brazil, Chile, Colombia, Ecuador, Honduras, Indonesia, Mexico, Panama, Paraguay, Peru, UK, and Venezuela. At this moment are with us in this webinar. Thank you so much. Greetings to all of you. Now, we start this dialogue based on the questions posed. So I will ask the speakers, Dylan and Baltica, to turn on your cameras so we can carry out this Q&A. We will start.
Solo un segundo.
Just give me a minute, please.
¿Puedo ir preguntando?
Sí, por favor, María.
Can I ask a question? Yes, go ahead,
Bueno,
Mari Carmen.
felicitaciones, las
Well,
dos,
congratulations
excelentes,
for the both
maravillosas.
excellent presentations,
Quería
wonderful
preguntar,
presentations.
¿realmente usted
I
cree
would
que
like
el
to ask,
racismo está
do you think that racism is increasing?
Esa es la pregunta.
That's my question. Do you
Comparativo
really,
comparativo a décadas anteriores.
comparing
¿Hay
to
más
previous
racismo
decades,
ahora,
do we have more
a
racism
pesar que
now,
estamos en el mundo de
despite
la
that we are
diversidad,
in the world of
inclusión y la
diversity,
equidad?
inclusion, and
¿Consideran
equity?
ustedes
Do you
que tenemos
consider
más
that
racismo
we
en
have
estos
more
momentos?
racism at present?
Thank you. Maybe I will start. I think the simple answer is that we don't know. There haven't been longitudinal studies measuring racism. To be able to measure racism is difficult. There are some scales you can use at an interpersonal level, though that tends to have been applied variably and across the world. There haven't been lots of long-term studies. The more difficult thing is to measure structural forms of racism. That's much harder. I think if I were to give an anecdotal example, what I see and experience as someone in the United Kingdom is different now than it was when I was a child. Overt acts of racism were much more common. Overt acts of violence were more common. So in a way that has changed. It is less acceptable now than it was. But some of it has just changed. It's not that to say someone, to come up with something, a racial form of abuse is not acceptable. But then to say something about migrants is still acceptable. We see politicians within our country talking about migrants in the same way that politicians used to talk about racial minority groups in the past. So some of it is just different. Some of it is there, but a little bit hidden. It's not as obvious as it was. The one thing that I think there have been trends where we have become more diverse, more socially aware. The opposite is also happening recently, the rise of the far right in many countries around the world. We see this in Europe, for example. We see anti-migrant, anti-racist rhetoric from many, many different political parties around the world. We see this anti-migrant sentiment, and that has health consequences. So that seemed to have increased. And I would say probably over the last 10, 15 years, maybe we've seen that rise. Maybe I'll stop there and hand over to Baltica, who can give you a better answer, I'm sure.
Gracias, Dylan. Thank you, Dylan.
Thank you, Dylan.
Creo que
I believe
la idea
that
de que el
the
ser humano es capaz de
idea
mirar a
that a
otro
human being can look
como
another one
distinto,
as different
diferente y distante de sí,
and
la
distant
constitución de
from
la otredad,
oneself,
existe, diría
there
yo, en la capacidad del ser humano
it is in the
desde que el ser humano
historically in the
está
capacity of
desde
human being,
tierra, que el
since
ser
we
humano
live
es
in
capaz
this
de mirar
earth,
al otro
that you can
como
look at the
distinto
other
y
one as
distante y
different and
constituirlo
distant
como una otredad.
and to build them as
El
another
desafío que tenemos en la
entity.
era de la
The
inclusión es
challenge
tomar
that we have in the
conciencia de que
inclusion
tenemos
era
esa
is to
capacidad
become
y
aware
del
that we have
daño
that
que produce,
capacity and the harm
para
that you can
trabajar sobre
produce,
esto y remediarlo y
to
educar
work on this and
correctamente.
educate
Saber
us
qué tenemos que
correctly
hacer para no
of what
caer,
we need to do not to
porque
fall
ya no
there,
necesitamos más guerras
because
en
we
el
don't need
planeta.
more wars than
Ya no
the ones we
necesitamos
already
más
have,
niños ni niñas
and we don't need more children
para
and
entenderlo.
death to understand that.
En particular en materia de
In
migración, que es
particular,
algo
in
de
terms of
los últimos
migration,
16
which
años,
I've been working for the last
especialmente
16
en
years,
Chile y en la región de
especially in
América
Chile
Latina,
and in the Latin American
vemos
Caribbean
una
region,
creciente
we
polarización
see a
política.
growing
Yo
political
no digo que
polarization,
necesariamente un aumento
and
del
I will say
racismo per
necessary
se,
increase in
pero
racism
sí
per
una
se,
mayor
but we
transparentización
saw
de lo que yo
a more
realmente siento.
transparency of what I
Una
really feel,
pérdida un poco de la vergüenza
a
y de
loss
la
of the
terciaridad
shame
social en torno
of the
a expresar
social
el racismo
in
sincero y
terms of
universal.
expressing my
Y eso es lo
sincere
que yo
racism.
documentaba
And this
en
is what I was
una de mis memorias
documenting in
iniciales,
some of
que
the
la
initial
opinión
slides,
pública está
where the
transparentando en
public
Chile
opinion
y que es
is
hoy el
transpiring
más
in
alto desde
Chile,
el año
and today
2016.
is the
No
highest
creo
since
que no lo haya pensado
2016.
antes,
I don't
pero
think
creo
that
que
they didn't
antes
think of
se
this
decía
before,
menos
but
con más
before
transparencia.
they
Y eso creo que
didn't
tiene mucho
use
que
to
ver con
say
lo
it,
que Dylan
and that
decía
has to do
de
with what
posiciones
Dylan
ideológicas
mentioned of
particulares que
particular
también
ideological
pueden
positions
construir
that
narrativas
can also construct
antimigrantes, racistas o
anti-migrant and
xenofóbicas
racist or
con
xenophobic
mayor
narratives
facilidad que otras.
with greater
Es algo
ease
en lo
than
que
others.
trabajamos en salud
And that is
y
something
que
that we're
creemos en la
working in
dignidad
health,
y el cuidado del
and that
ser
we
humano
believe
por
in the
encima de cualquier
dignity
otra
and care of
categoría.
human being above any
Debemos
other
mirarlo
category.
con especial
We
atención,
have to look with,
porque la
we have to
atención
pay
a la salud
special
y el
attention
cuidado del otro
because the
está
care of
en la
health
base
of the other
hipocrática
is in the
esencial de nuestra
hypocritic
vocación de
essential
servicio
basis
cuando
of
elegimos una
our
profesión. Y
when we
todos,
choose this
y eso
profession and
creo que
not
es
another one.
de excepcional facilidad.
But sometimes it's
Gracias
missed
por
with
la
these
pregunta.
old perceptions. Thank you very much for your question.
Estaba muteada. Muchas gracias a ustedes por
Thank
la
you very
respuesta.
much
Yo tengo
for
otra
your
pregunta.
answer. I have other questions here. It says,
¿Existen estudios
are there any
longitudinales basados en el
longitudinal
impacto
studies that
racismo
evaluate the impact of
a lo
racism
largo
and
de nuestra
discrimination
vida?
throughout the course of life?
Se la voy a pasar a Dylan.
Dylan, you have the word. You have the floor.
Te comento, Báltica, que era para Dylan.
It was for
Adelante,
Dylan. That
Dylan.
question was for Dylan.
Largely, most of the studies are cross-sectional. There aren't many cohorts. I can't think of good cohorts off the top of my head. There are some. Our colleague in New Zealand is running a cohort study with young people. I don't think they span the whole life course. So there are some that do shorter follow-up periods. I think it goes back to an issue of how to measure racism well, how to measure it well in the location that you're in. 2, a funding issue. Studies on racism are generally not funded. So there isn't a lot of research that looks at it. And Baltica is putting some studies into chat. And for me, part of this work has been to make people, such as myself, think about racism when they're running studies. That whatever you're doing, if you work on cancer or respiratory health, you add in estimates of racism within the work that you're doing so that it becomes more mainstreamed. But I think it goes back to that last question as well. We don't know very well over long time periods what's happening.
Báltica, ¿quisieras agregar algo o hago la siguiente pregunta?
Comparto lo que dice Dylan. Yo creo que la respuesta correcta es que no hay suficiente información. Hay algunos estudios que discuten teóricamente y con algún grado de seguimiento, pero siempre muy corto, sobre todo para medir lo estructural del racismo y discriminación.
Muchas gracias, Báltica. Me gustaría comentarle a nuestro intérprete de que estamos escuchando la traducción en inglés. La estamos escuchando.
Yes,
Jorge. Bueno, tengo otra pregunta.
I have another question, and this is for Baltica.
¿Cómo los enfoques neoconservadores,
The neoconservative approaches, the polarization of approaches, and the diffusion of misinformation are affecting access to health? What do we see in our region? Wonderful question. Thank you so much to the one who sent it. The construction of discriminatory or racist narratives given to what we comment to the previous 2 questions is part of the human being capacity. And that occurs when we have negative emotions to what we define as the other. That it usually gives us rage, fear, or hate. And through those emotions, we generate mental constructs, ideas, belief systems where we position a place of inferiority to that we perceive as distant or different to us. And few times, not too long ago, we did a scope review for Latin America and the Caribbean, and I'm going to show the link in the lab with discriminatory narratives and effects on the health in our region. And we found some ideas that I'm going to summarize, but you can look at the text later. There is interesting literature in our region in order to think, both scientific and social literature. We found first that there are discriminatory narratives that can be identified in public discourses of country authorities or health authorities in our region, and we found in social networks and in press communication, TV, newspapers, etc. These discrimination forms have effects on health, especially in mental health, in migrants and refugees in our country. And in addition, they have an intersectional dimension that affects even more when these migrant and refugee people are women, are children, have a dark skin color, or are indigenous. So this intersectional and multiplicity of layers that not only add but multiply in their health risk is real. And finally, there has been documentation of discrimination and racism experiences inside the health systems in our region towards migrants and refugees, especially through cross-sectional studies and
Y les voy a
qualitative
poner
studies.
ahora en el chat
And now I'm going to
la
post in the
referencia para
chat
quienes quieran conocer.
the reference
Muchas gracias.
for you. Thank you.
Estaba otra vez muteada.
Once again, I was
Gracias,
muted.
Báltica, por tu
Thank you,
respuesta. Quería consultar a
Baltic,
Dylan
for
si
your
quería
question.
agregar
I want
algo
to
más.
ask Dylan if you would like to add anything else.
Sorry, the question was around
La pregunta, a ver, era sobre...
access to the healthcare system.
Sí, que cómo los enfoques
Yes,
neoconservadores
how the
y la
neoconservative
polarización de
approaches and
información y
polarization
desinformación están
and misinformation
afectando la
are
salud.
affecting the access to health.
Eso.
That was the
Okay.
question.
So, I mean, to give the British example, in a way, it's unusual because we have a national health system. We don't have a health system such as in the USA that is much more private. But even in our own health system, we have differences in access. I mentioned for migrants, for example. And this comes from this anti-migrant attitude. This comes from this idea that people from somewhere else are coming here to our country, taking our resources, and that isn't good. We need to stop those migrants. I was interested in actually, Baltica, looking at your slides that the migration numbers in Chile are actually very similar to the UK in absolute numbers. It's about the same numbers of people coming and leaving. But that anti-migrant rhetoric, which comes from this same populist angle and attitude, results in policies that try to stop people, try to demonize people, that result in the health consequences that we see, the charging for migrants, the poorer health amongst migrant populations, the people coming in late and even, to the health system late. And that isn't a good way to do things as well. It leads to those people coming in an emergency situation, the costs being much higher. And even I would give one example from my own family. My son had some tests in the hospital, allergy tests. And then we got a letter afterwards asking if we should pay. And it was very odd because we are British citizens. My son was born in the UK. We shouldn't have paid. But the only thing I can think of is because of my name. My name sounds like it's foreign, that we got this letter. And I kind of know the health system, I understand it, but I can't see, even when it's done very badly as well with these racist undertones. And that results in children being unwell.
Sí. Bueno, tengo otra
Well,
pregunta. Muchas gracias, Dylan.
Thank you very much, Dylan. I have another
¿Cómo
question.
se
Is there
percibe la
any
diferencia
difference
entre la discriminación a los
between
migrantes
discrimination
domésticos a los migrantes
to
extranjeros?
domestic migrants
Qué buena
compared to
pregunta,
foreign
muchas gracias,
migrants?
María.
Thank you very much for your
Existe en
question.
Chile, voy a referirme a Chile, que es la
I'm going to
institución que más me
speak
preocupa.
about Chile because that's the
De los
information I
años 40
have.
a 60
In
en
the
Chile,
40s to
hasta
the
los
60s in
80,
Chile, up to
hubo un
the 80s,
movimiento interno muy
there was
grande de
an
personas
internal
del sur de
movement of
Chile,
people from the south of
población
Chile,
indígena mapuche en particular,
Mapuche
hacia la ciudad de
indigenous
Santiago, que
population,
está en el
towards the
centro.
city of Santiago,
Desde el
which
sur
is in the
se
middle of the
desplazaron
country.
internamente
From
a la
the
zona
south, there was
metropolitana y
internal
empezaron
migration to the
mujeres
metropolitan
jóvenes
area,
de origen
especially
mapuche
young women
para
from
trabajo
Mapuche
en
origin
servicios domésticos
to
en
work
casas.
for domestic services at
Eso
home.
generó que,
That,
y quiero retomar lo interseccional,
and I would like
era
to
la
talk about the
oportunidad de personas
intersectional
muy
again. That was the
pobres por
opportunity
razones
of
históricas
very
del
poor
pueblo
people,
indígena en el sur
for
de Chile,
historical reasons of
buscando
indigenous people
oportunidades
in the south
laborales
of
y
Chile,
esa oportunidad
looking
ven el
for working on
desplazamiento interno
opportunities.
como una
And
oportunidad para
so
trabajo,
this internal
pero
displacement
también
as an
con
opportunity
oportunidades
to get a
laborales
job,
reducidas
but
hacia lo
also
doméstico
for
en casa, como
this opportunity were
amas de
reduced to
casa, y también con ciertas limitaciones del
domestic
pago que se establece, de la
work
extensión de la
as
jornada y la
servants
informalidad que se
and
presenta en
with
ciertos contextos.
informality and different
Mujeres
labor
jóvenes
conditions.
de cierta
These were young
estatura,
women
de cierto aspecto
for certain height and certain phenotype
pueblo indígena,
from
de
an
zonas
indigenous
rurales,
population
se
from rural
desplazan
areas
a
are
zonas de
displaced
clase
to areas of high class in the capital city to do domestic chores. And this is an example of intersectionality that goes through all types of human. And in the international mobility is that because you lose all your support networks and you come to a different cultural political space. The internal migration that occurred in Chile between the 40s and the 70s of the past century also generated a cultural shock because many of them bathed on the rivers and never took a shower or used a bathroom. So there was a cultural shock when they arrived to Santiago, the capital city. And when that happens with another space with political codes, other economic logics, other health systems, because they go through political borders, that makes the adaptation and integration challenges are higher, or the fear to be deported. And that's usually higher at higher levels. Thank you very much. Thank you, Baltica. I don't know, Dylan, you would like to add anything, or should I go for a question directly for you? Okay, Dylan, in your experience, is there reverse racism?
This is a very
Esa es una
controversial
pregunta
question.
directa para ti.
This is a direct question to you.
Yeah. I think most scholars will say that that doesn't exist, that racism is built on historical hierarchies that place certain people at the top of the hierarchy and certain people below. I would appreciate that in different countries and different localities, that hierarchy can be different. We work in, I mentioned lots of different forms of racism for indigenous people, against caste and color, and religion, for example, varies from country to country, that certain groups are more powerful in one country, and in another country, another group is more powerful. So that hierarchy can be different. But usually, if we think about racism, and if we think about the colonization, really, of countries around the world, it is white supremacy, that white people were considered to be better than others. And I think the idea that you can discriminate against people, you can discriminate against white people, Asian people, but really that hierarchy is the thing that is more important, and it's built into multiple generations of destitution, of violence towards communities, and that's very difficult to change. So I would largely say that it isn't something that exists, though in localities it can look different.
Muchas gracias, Dylan. Báltica, ¿deseas agregar algo más? No. Tenemos otra pregunta. Te estamos escuchando, Jorge, en el inglés. ¿Qué
We have another
responsabilidades
question.
deberían asumir los países
What
para
responsibility
los
should
colonizadores
countries have
con
who
los
were
países
previous
que
colonizers
y
with the
en
countries that they exploited
a la
and they
población por el
suppress the
establecimiento
population
del estigma,
by
discriminación
establishing
y
this
racismo?
stigma of racism and discrimination?
Es para ambos. Esas sí son ya
For
las
both
preguntas
of
de
you.
acá en adelante, las ponen para ambos.
The following questions are for both of you.
Dylan, would you like to start?
No, you start.
Okay. Muchas gracias por la pregunta.
Thank you very much for that question. Very interesting. I think that we have the historic dimension of colonization and the post-colonial effects of that global experience of South with regards to the North. But there are also the modern present effects, as Dylan mentioned, in terms of climate change, for example. So I think that we need to have an historic look that also adds layers of the problems that we have at present and in the future. I think that the invitation that we have from the South is to become aware of the colonial and post-colonial process has done. At a personal level, in our own history, I have ancestors from Spain, and all of them in our region have a history of migration which is still alive 4 or 5 generations ago, or maybe more recent. So I think, and I'm talking in a very personal terms, we need to learn to accept and embrace that colonization is part of our history, but also brings challenges in order to break those racism and discrimination schemes that we perpetuate and learn since that time. The way how we treat among us, being children, grandchildren of migrants, and rejecting current migrants ignores our own history. We need to embrace our own history, and with that, become aware of the effects that we ourselves perpetuate of the colonial and post-colonial times in order to create narratives and alternative human relationships to the ones that are prevalent now, and put the human being with dignity as equal in all the world. That's my answer. Thank you.
Muchísimas gracias, Báltica.
Thank you.
¿Queremos agregar algo más o voy con la siguiente pregunta?
Would you like to add anything else?
Adelante.
So, first I will say these are very challenging questions that we're being asked. If we were to think across the expanse of history, empires have been around for centuries, for millennia, and empires exist to expand their boundaries for largely capitalist reasons. And those empires are across the world. The more modern phenomenon of empires is mostly Northern European countries going around the world to Latin America, North America, Asia, Africa, across the world, and taking over, colonizing those countries in different forms, in different ways. I would see that these countries in Northern Europe still have some responsibility towards the countries that they went to. My own example, my family is from Sri Lanka, and then we moved to the United Kingdom. The British Empire, prosperity of the British Empire was built on taking resources from these countries, from South Asia in particular. India was one of the richest countries in the world. Coincidentally, when the British arrived, it took resources from India, from the Indian subcontinent, and now certainly the parts of India that were the richest in the world are now some of the poorest parts of the world. This part of northeastern India in particular. How that exists and the forms that take is difficult, and that's a very kind of controversial argument and discussion that we have within the UK, the responsibility towards these countries that are sometimes growing, sometimes very powerful as well. The Indian economy is huge, the Indian country is huge. But thinking of my own sort of backstory, my parents, their education was built on the British education. The idea was that they would come to the UK and learn and train in the UK. There was this extraction of resources from countries like Sri Lanka. So I think it's disingenuous to totally separate current situation within a country like Britain from its colonial past. And the form that takes, and the people have argued for reparations towards other countries. I think certainly within the climate change discussions, there are responsibilities that rich northern countries have towards the resources that they've taken from others.
Muchísimas gracias, muy importante.
Thank you very much.
Me preguntan o me piden que pregunte, ¿qué
I have
avances
another question.
normativos
What
son hitos claves para reducir
standards
la
have been
segregación institucional?
advanced in order to decrease
Adelante.
institutional or government
Voy a tomar
discrimination?
esa, yo agradezco también la pregunta.
I
Gracias por
thank
la
you very
pregunta,
much for your
pregunta,
question. Thank you
sí.
for the wonderful
Da cuenta
questions.
no solo de que
It
este es un
indicates
tema
not only that
circular,
you're interested in this topic, but
buscando
you're also
soluciones concretas a un
looking
tema tan
for
complejo y multidimensional.
solutions for
Así
this
que las
complex
agradezco
issue.
muy sinceramente.
So sincerely,
Desde el
thanks
ámbito de
to
la
all.
salud o de los sistemas
From
de
the
la salud o
health
la
or the health
política
systems
en materia de salud pública,
or
voy a
health
responder como desean,
public health
pero es
policy, I'm going to
transferible
respond.
a
but this can be transferred to different sectors. For what we have learned from our research in this topic, there is first the opportunity for regulation to build health systems, health services, hospitals, etc., build teams that are aware of racism and discrimination that can be standardized, but also needs to be educated and constantly developed, as well as strategies to build environments free of discrimination. So I talk about the regulatory aspects and the education of each health personnel, so that when you see or are exposed to situations of racism, you know how to act, and the regulations will promote those actions of rejection and zero tolerance to any type of racism and discrimination. And in order to do that, we need to know what is racism and discrimination, how it's being seen, what behaviors will document that, and what do I have to do, which is the right thing for those situations if I experience them. So we require regulations that teach me, that tell me what I need to do, and that support me in time on the personal basis and institutional or collective basis. In addition, I think we require to review the curricula of pre and post degree in terms of what being educated in terms of racism and discrimination, or what not is being taught, and how can we support the construction of new health leaders considering education and public policy. But I'm focused in health as an example, where when you review the curriculum of training is very thin or inexistent. And so there is a curriculum challenge that is quite significant. A third dimension has to do with what we today see and validate in terms of social communication and the media. Today, journalists, communicators, and authorities from countries and governments in health may say things that are directly discriminating or acting as a racist narrative, but they don't have no way to control or regulation. There is the opportunity in terms of public policy to establish correct forms of language and narrative that do not allow and that can generate some type of regulation in terms of press communication or media communication. With that, I'm going to conclude with some examples, because this can be reproduced to different sectors in the construction of countries and societies. Perhaps, Dylan, would you like to add something else?
I'm sorry, I missed the first question here. If you could repeat that question.
¿Qué responsabilidades
What
deberían
is the
asumir
responsibilities that the countries
sí, y los que suprimieron, esa no es, ¿no? Sí, me quedo.
La siguiente, sobre normativas. ¿Qué normativas?
¿Qué avances normativos son hitos claves para reducir la discriminación institucional o desde el
What are the
gobierno?
standards or norms that have been implemented to reduce the discrimination at government level?
Okay. Thank you. So I think, Bartka, I heard your answer. You were talking about the health system in particular and training. One thing I'd say, if we think about the relationship between the structural, the institutions, the individuals, if you can change the structure of a country, so that's potentially changing the constitution, changing the laws within a country, those are the things that tend to have the biggest effects. So we look at anti-caste laws, anti-caste discrimination laws in India, for example, in the Indian constitution. We think of South Africa and a change to the apartheid laws. These are things that can happen at a national level that can have big changes throughout a country. Not without problems, but they can potentially shift tendencies, understanding within a country. One thing I would add, just on a much more specific, granular level, postgraduate training, we've been looking at that within a UK perspective, trying to understand who's talking about racism, who's teaching racism. And really, for us, it's only a small minority of specialties within the UK that racism is included within the curricula. So I think there's a lot to do within health professional training from an undergraduate level to postgraduate level.
Y una última pregunta para
A
completar
final
lo que
question.
acabamos de ver. ¿Y los líderes? ¿Qué
And
hacemos
what
con
about
los
the leaders?
políticos o
What do we do
líderes
with the
políticos?
politicians, the political leaders?
Influyen ellos con este
How can we
tema.
influence them in terms of
Pregunta, ¿qué
racism?
medidas se puede tomar al
What
respecto?
measures can we take in this regard?
Again, it's not an easy answer, and it depends very much on where you are in the world, who your leaders are. Going back to the populist agendas from many leaders, it's true that there's a huge proportion of the electorate who are seeking these populist leaders. Some of them have lost as well, though. We see in France and the UK, we've moved more to the centre left, in other countries, in Brazil, for example. So it isn't that there is always a trend towards more racist actions. I think there is something about what health professionals need to do, academics, clinicians, because they have power within the system. They usually have a voice that is heard, a voice that is respected. In most countries, health professionals have that power. And I think they need to talk about these issues. They need to advocate for these issues. About the people that they're seeing, the patients that they're seeing, they need to ask the questions. Why is this child unwell? What is happening in this child's life that leads them to being here with this illness? And then what can I do as a health professional to try and stop that? I know that's not easy. I know it's difficult to do more work, to step outside. But there are organizations that work in advocacy in every country, in the UK, I'm sure, in all of the countries that you're in. And those organizations have levers to reach the leaders. And I would, really urge people to try to take on this challenge, because I think you do have power to make a difference.
Muchísimas gracias, Dylan, Báltica. Sabemos
Thank
que
you
tienes un
very much,
compromiso
both of you.
a realizar,
Baltica,
pero no
we know you have to leave.
cerrar este
But
coloquio
before
sin
closing
tener tanto
this,
de ti, Báltica,
without
como
having
de
from
Dylan,
you, Baltic, as well from Dylan,
mensaje
a
para todos
final
los que nos están
message
escuchando,
for all
que
the
no pase de
audience.
un minuto, por favor.
Just 1
Adelante,
minute
Báltica.
final
Claro que sí.
message. Go
Primero,
ahead,
gracias
Baltica.
de nuevo por
First
este
of all,
espacio
thank you
riquísimo
for this
excelentes
space
preguntas
of
y mensajes.
excellent questions
Quedo
and
muy
exchanges.
disponible, quien así lo
I'm
desea,
available
contacte directamente
to
si
be
desean
contacted
continuar
directly if you want
revisando
to
este tema o
continue
conocer
reviewing
más
this topic or to
documentos o
learn
estudios similares.
more about
Mi
similar
comentario de
studies
cierre
and document.
simplemente que
My
sepan
closing
en el
comment is
futuro
to say, don't be afraid
adentrarse a
to
investigar
become
o a
educated
comprender
and to
mejor este
investigate and to
tema.
understand this
Genera
topic.
mucho miedo el tema del
It
racismo y la
generates a lot of fear when we talk about
genera
racism,
preocupación, pero que
discrimination.
siempre
It generates
quizás
concern.
por ese mismo miedo
And perhaps
nos
because of that
alejamos de
fear,
él y no nos
we
informamos
go
lo
away and we
suficiente.
don't have
Y
enough
desde el ámbito de
information.
la salud tenemos
And
un
from the health
desafío
area, we have a
urgente
challenge,
de tener
urgent challenge
personas y
of
profesionales
having people and
entrenados en el tema
professionals
de
who are trained
discriminación y
in terms
racismo.
of discrimination and
En la
racism.
época global de
In the
inclusión e integración
global
y
era
equidad,
of
como decía
integration
María del
and
Carmen,
inclusion
de
and
incluso
equity,
de
as Mari
multiculturalidad,
Carmen mentioned,
donde
and
seguimos
also
hacia la interculturalidad que hoy
multiculturality with
enfrentamos, que no
challenges that
tengamos
today we are
miedo
facing. Don't be
preguntarnos
afraid to
qué es
ask
racismo,
ourselves
qué es la
what is
discriminación
racism,
y
what
cómo
is
se puede
discrimination,
evitar.
and how
Muchas
can we
gracias.
approach it. Thank
Muchas
you very
gracias,
much.
Báltica. Adelante,
Thank
Dylan,
you,
por favor.
Baltica.
En un minuto,
Dylan, go ahead,
mensaje
please.
final.
One final, 1 minute.
Again, thank you very much for asking me to speak today for both of us. And certainly the questions were challenging as they should be. I think my just final point is that racism is a global health threat that affects the lives of the people you see across the world. I work in child health and it affects children's health. And going on from what Baltica says, we have to learn about it. We have to challenge racism, and that's my call to everyone listening to this, that we have to take on this challenge, think about it, understand it, then advocate for change.
Muchísimas gracias, Dylan. Agradecemos
Thank you very much,
también a
Dylan.
todas las
We
preguntas
thank
que nos han enviado
all
por
the
esta
questions
mañana.
being sent.
Algunas no hemos podido
We were not able to
responder,
answer
pero
them
es
all,
un tema que da para más y
but
lo vamos a tener en
we will
cuenta.
take them into account
Reiteramos el
for different
agradecimiento
topics or
a
next webinars.
Báltica, a
We
Dylan,
reiterate our
a
thanks to Baltic and Dylan for wonderful
Hemos recibido
presentations.
muchísimas
We have received many
felicitaciones a lo
congratulations
largo de todo
throughout
el webinar
this
y nos gusta
webinar,
hacerles llegar a ustedes las
and we
felicitaciones,
ask
¿no? A
them,
través de las
they
redes
ask us
sociales.
to give
Agradecemos
you
también
our
a
thanks.
todos los que han
We also thank
participado
to
por
all
parte
the
del equipo de
participants
Horas con
on the
U,
Horas con U
especialmente
team,
Yadira,
especially
Rob,
Yadira, Rob,
Milagros,
Milagros, Ruby,
que siempre nos apoyan
for their
a lo largo de todos nuestros webinars.
support.
Muchísimas
Thank
gracias.
you,
También a
thank
todos
you
los que han
so much, and
participado de
to all
alguna
who have
manera u otra
participated
en el desarrollo
in
exitoso
this
de esta
successful activity.
Ahora, para dar
Now,
cierre a
to
este
close,
evento, le voy a hacer la palabra a
I'm
la
going to
doctora María
ask
del Carmen
Dr.
Calle.
María Carmen Calle
Adelante, por favor, doctora.
for their closing comments. Go ahead, Dr. Calle.
Mis primeras palabras son
My
de
first words
agradecimiento.
are to
Muchísimas
thank.
gracias, Dylan.
Thank you
Muchísimas
so much,
gracias,
Dylan.
Báltica.
Thank you so much,
Realmente
Baltica.
es un tema que debe
This is a
tocarse,
topic
es un
that
tema
needs to be
en el que estamos
taken into
comprometidos
consideration. We are
definitivamente
committed.
nosotros desde la
We
Organización
definitely,
Mundial de la
from the
Salud.
Andean Health
Es uno de los
Organization,
temas que
this is
siempre
one of the
hemos
topics
querido
that we always
enfrentar
wanted to
con bastante
discuss,
evidencia, ¿no?
and
Y es por eso que nos sentimos muy
that is why
contentos
we
de que hayan
are
sido ustedes
very
quienes nos
happy
hayan
that
presentado
you
el tema
too
en
were
nuestro
the ones
webinar.
who presented this
Quiero
topic in
compartir
our
con
webinar.
ustedes que
I
estamos
would like to
hablando
share
de casi
that
400
we have
personas
almost
de
400 people
17 países
from 15
y que
different countries,
realmente este tema es un tema
and this is
súper importante.
a
No voy
very
a repetir lo
important
que han
topic.
dicho.
I'm not
Lo
going to repeat
único que voy
everything
a
that has been
pedirles
said.
es
The
que
only thing that I'm
tengamos
going
los
to ask
ojos
is
hacia los
to
niños.
look to
¿Ok?
our children.
Una cosa es que a uno le suceda un
One thing
acto
is that
de
you
racismo o
suffer a
discriminatorio
racism
a
or
los 10
discriminatory act, and
Otra cosa
that
es
you're
que les
20 years
suceda a
old,
los 5, a
and
los
this is
7,
completely different
a los
when they are
8,
5,
a los
7, or 8
10
years
o a
old,
los 12 años.
or 10 or 12
Realmente
years
es un
of age.
trauma. Es un
It's a
trauma
trauma.
y sabemos muy bien todos que es
We
real.
know that trauma
Ahora, nosotros
is.
tenemos normativa
Now
mundial.
we have
Nosotros
world
tenemos. Yo sé que
regulations.
hay que aterrizar más
I know that
países,
we need to
pero nosotros
land in
tenemos
each country,
contratos
but
sociales
we have
que hemos
social contracts
firmado como
that we
países.
have signed as
Y uno de
country.
ellos, que es uno
And one
que
of
me guía
them
mucho a mí, no puedo
that
evitarlo,
guides
soy
me,
pediatra,
I'm
así
a
que veo niños,
pediatrician, so
y uno de los
children.
temas es el
And
Comité
one
de
of
los
the
Derechos
topics
del Niño.
is the
El
Committee of
Comité de los
the
Derechos
Children's
del
Rights.
Niño en
This
muchas
committee
observaciones generales ha
has
sido
many
muy
general
claro
observations, has
respecto del
been
racismo.
very clear in terms of
Y una de las
racism.
primeras
And one of
observaciones,
the
que es la
first
número 1,
observations, number
habla
one,
acerca de lo que ustedes
talks about
mencionan,
what
los
you
dos,
mentioned.
la
You too mentioned
necesidad de que el
the
tema
need
sea
that this
incorporado en
issue
la
be
educación
added,
desde los primeros
incorporated in
años.
education from early
Porque a
years.
fin de cuentas,
Because
ese
at the end,
termina siendo
about the bottom line is what
el
you end up
resultado
being.
de lo
You're the
heredado,
result of what you
lo
inherited,
aprendido
what you
y lo
learned,
decidido.
and what you
Eso somos
decided.
nosotros.
That's
Lo
what we are.
histórico, lo que aprendemos y al
This the
final
history
al
and
lado
what we
vamos.
learn and
Ese
which
es
side we go to.
eso somos.
That's
Yo
what we
creo que el
are.
tema de niños es
And I think that
importantísimo en el ámbito
children
de la
are extremely
educación
important in terms
desde
of
los primeros
education
años.
from their
Porque
early
desde los
years.
primeros años, si a los
Because from the
niños se les
early years,
educa
if you
a tratar
teach
a
children
todos de
to
una
treat
manera
everyone
respetuosa,
with
sin
respect and
hacer
dignity,
estos,
without
sin dejarse llevar por estas narrativas que te hablan de estereotipos,
using this narrative of
definitivamente
stereotypes,
las cosas van mejor.
definitely
Pero
things will
también
be better.
hace la observación
But
general
we
número
also made
11,
this general
que la
observation number
ONU
11, which talks
preponderantemente de la población
mostly
indígena.
about the indigenous
Nosotros en
population.
América Latina
We
tenemos
in Latin
mucha
America
población
have
indígena
a lot
y que
of
siempre
indigenous
ha sido de
population,
las
and that
poblaciones
has been one of
más
the
con mayor
most
vulnerabilidad, y
vulnerable
lo sabemos por los
populations,
números, por los
and we know that
resultados,
because of the
por los
numbers and
indicadores,
figures
por todo,
and the
¿no?
indicators.
Y otra cosa importante es
And
el
another
tema de la
important thing
violencia.
has to
La
do with
violencia que tiene
violence.
que ver también
violence has to do with racism. And I love those comments that you put. That's so
exactos, ¿no? Eso de no
exact.
desconocer 10 años de, ¿no? 10 años de trabajo
Not
como si nada,
neglect 10
o
years of work
cobrar
just
el
like that,
seguro
or to
al hijo
charge
de
for
tu
the insurance
el apellido,
for
¿no?
your son because of your last name
No, no se supone, son ingleses, ¿no?
because you're
Me
British.
refiero a ese
So,
tipo de
I mean, to
violencia.
that type of
Eso es racismo
violence.
y es violencia
That is
psicológica.
racism and
Comentarios
psychological
a los peruanos
violence.
no les venden,
Those comments
¿no?
to we don't sell Peruvians.
Esa es violencia
That's
psicológica,
psychological
racismo, que
violence
también
and
es la
racism,
violencia más frecuente,
and also the most frequent
que
violence.
también queda, porque
And it's the one that
muchas veces
stays
dicen
because
las
many people
palabras
say
se las lleva el
the
viento.
words are
No,
taken by the
no es así.
wind, but that's not true,
No se lo dicen todos los días.
especially if you
Más
hear that
si
every
uno
day,
está con el cerebro
and more if your brain is being formed. Remember that our brain is still growing and developing until we're in our 20s. So let's think also in young adolescents. And in terms of adolescents, which are one of the most discriminated groups, when you talk with us, we have experience in terms of migrants. But we're not only talking about the external migrants, we're also talking about internal migrants. I really like this comment of the Mapuche group, because in those years in Peru, we had the same situation with the people from the highlands, and 40 years have passed by, and there's still racism and discrimination in our schools. So, as you say, there's an astounding topic. There's still a lot to be done, but we will continue your advice given by you two. But first, we need to learn more about this issue. We need to read the Lancet, all the publication, and not only have empathy, but we need to make concrete actions. And from our institution, we can contribute to Andean policies. We issue Andean policies. And one of the topics that's been worked in the next 2 months is the policy against stigmatization that also has to do with racism. Sometimes stigmatization is just against HIV or LGTB+, but they all related. Let's not forget something that always comes is intersectionality. In our strategic guidelines, we not only talk about integrality, not only talk about intersectoriality or multiculturality, but we also talk about how important it is to consider intersectionality. It has been a wonderful webinar. I'm very happy. Thank you very much to the speakers. Thank you very much to Gloria and whole team. Thank you for the questions, wonderful questions. And see you Tuesday, next Tuesday. It's not Thursday, it's Tuesday, July 16, and we talk about anemia. New measurements, new challenges. Thank you very much. Good day, good afternoon, good evening. See you soon.